Good evening, everyone, and welcome to the third season of Journal Club meeting, a joint meeting of MOS and BOA. It's with great pleasure and the thank you for the enthusiasm and joining us. So the vigor of Journal Club meeting is continued for the third season. I would ask the President MOS to open the meeting. Sir Santosh sir, please
Yeah,
open the meeting.
thank you, Dr. Vaishal.
Yeah.
Respected teachers, senior colleagues, and dear friends, greetings, very good evening, and wish you all a very happy and prosperous new year. It gives me immense pleasure to attend today's first Journal Club meeting of my tenure as Honorary President of MOS. On behalf of MOS, I welcome you all to this unique activity curated by Dr. Vaishal Kenia and his team. I thank and congratulate Dr. Vaishal Kenia and his team for holding such a journal club meeting for last so many years with a great success. I am also grateful to him for taking this activity under the aegis of MOS and BO both. As you know, these journal club meetings stimulates students to read current literature. In addition, they also help improve the students' skill of understanding and debating current topics of active interest in their field. Over time, the goals of Journal Club have evolved to include discussion and overview of literature, which would eventually improve patient care by incorporating them into the practice. That is evidence based medical practice. I am looking forward to a great discussion today on the very vibrant topic of today. Thanks to Dr. Vaishal Kenia, all teachers, PG, and experts for their participation. And also, I thank Dr. Vaishal Kenia for giving me this opportunity to speak in front of you. Over to Vaishal Kenia.
Thank you for sir for those encouraging words and welcome Dr. Lane sir and I would like you to give your ashirwad to this meeting sir the season third.
Thank you, Vaisal. Thank you, everybody. Vaisal, I think very enthusiastically this season third he has started. This meeting, I think it is just because the Vaisal's hard work. This meeting is going on. The students are presenting the topics, and I wish you all happy New Year. Whatever you wish should get fulfilled in this new year. And thank you, Vaisal and all BOA. The Himanshu has also joined. The Nikhil has joined. So Manish has also joined. Everybody from BOA and MOS. I think Santosh has just spoken. So my best wishes, and we'll go ahead with the, you can say, the presentations. Thank you, Vaisal.
Thank you. Sir Himanshu sir please give your comments and blessings to this third season.
So Journal 3.0, welcome. I think wonderful going so far. Thank you so much for inviting me. It's a great initiative, and more important, besides the initiative, is to continue doing the same thing again and again, even when there was a low turnout earlier on. It's a perfect time that education is being imparted, and now with the way we have digital medium, we don't have to meet physically. And this has made life a lot more easier to do their meetings like this, and thank you so much for holding it. A very healthy, happy new year to everybody. Today's topic is absolutely fabulous because whether we smile, we always smile all together, the patient and the doctor will smile.
That's the smile. Yeah.
Whether we do smile or we do the LASIK or we do whatever technique. Let me make one point certainly clear that LASIK has the experience from 98 onwards, and we haven't seen so many blind patients, nor have we seen so much of ectasia. LASIK is here to stay, smile is here to stay, technology is here to stay, and all these have been there just to help us so that we get rid of the glasses the best scientific way. I remember 1991, first time when I went to the US, and the first examiner machine I saw, it was an amazing thing. 1994 US FDA approval. So it's been 30 years. And I remember when we started practice, we had to kind of convince patients that it is a safe technique. Today, this generation doesn't have to prove. It's already there, being done, being widely done, and a lot of patients have done it. So there is a lot of example which is there in front of us. Thank you. Over to all the great speakers. Gaurav, welcome to the show. And we have a fabulous lineup here to discuss what's going to be going on right now. Thank you so much. All the very best for the day. Hi, Gaurav. Wonderful to see you.
I'm so sorry. I got a little late joining. I'm so sorry.
No problem.
So I think we'll move towards
Yeah.
the
So
club.
Parul, please introduce our faculty today.
So today's article we have is patient-reported quality of vision in a prospective randomized contralateral eye trial comparing LASIK and SMILE. Today it will be presented by Dr. Mohan, and it will be co-moderated by me, Neeraj Asrani, Zain Khatib, and Dr. Archana. We have our fine faculties, Dr. Gaurav Luthra and Dr. Praveen Vaddavalli. I think they don't need any introduction. They are very well known in our circle. So with this, I would request Dr. Mohan to share his presentation. And even invite, I would like to even thanks Dr. Sen Gupta, who will be joining soon. He's a statistical expert with us. Yeah. So Mohan, please share your presentation.
Yes. Thank you, ma'am. I'll just share my screen. Is my screen visible, ma'am?
Yeah.
Good evening, everyone. At the outset, I would like to thank Maharashtra Ophthalmological Society and Bombay Ophthalmologist Association for giving me this opportunity. So the topic for today's journal club is patient-reported quality of vision in prospective randomized contralateral eye trial comparing laser-assisted in situ keratomyolysis, that is LASIK, and small incision lenticular extraction, that is SMILE. Study done by Kevin K. Maital and was published in Journal of Cataract Refractive Surgery in 2023. Introduction. Laser-assisted in situ keratomyolysis is one of the most successful elective procedures worldwide. Small incision lenticular extraction, a more recent procedure, has gained in popularity and has also shown to have excellent outcomes. There are numerous studies comparing objective measured outcomes between LASIK and SMILE. These parameters may not entirely predict subjective quality of vision and ultimately patient satisfaction. Postoperative visual symptoms like glare, halos, starburst can lead to decreased patient satisfaction. Hence, when comparing two procedures, patient-reported measures are important to assess for the differences in day-to-day visual function. Methods. Aim of the study is to compare patient-reported quality of vision and visual symptoms in participants undergoing wavefront-guided femtosecond LASIK in one eye and SMILE in the contralateral eye over the 12 months of follow-up. Study design is prospective randomized contralateral eye study. Study center is Bayers Eye Institute at Stanford University, California. Participants were randomized to receive either wavefront-guided femtosecond LASIK in one eye, LASIK or SMILE in the dominant eye, and other procedure in the contralateral eye. A single surgeon performed all surgeries. The study adhered to the tenets of Declaration of Helsinki and was approved by Institutional Review Board. Written informed consent was obtained from all participants before their inclusion in the study. The inclusion criteria. The key inclusion criteria were 0.75 to 8 diopters of spherical myopia with less than 3 diopters of astigmatism. Exclusion criteria. Patients with greater than 1.5 diopters of spherical or 0.5 diopters of cylindrical anisometropia, the central corneal thickness less than 500 micrometer, topographic evidence of keratoconus, unstable diffraction, and patients with history of previous ocular surgery or autoimmune diseases and pregnancy were excluded. For eyes receiving LASIK, a 9 mm diameter flap at 100 mm depth with a superior hinge was created using femtosecond laser. Using the scans from the aberrometer, wavefront guided ablation was performed with the excimer laser. For eyes receiving SMILE, a 6 mm or 6.5 mm diameter refractive lenticule at 120 mm depth with a 4 mm superior tunnel incision was created using femtosecond laser, which was gently dissected and removed using SMILE forceps. Post-operatively, all patients received topical prednisolone acetate, 1% ophthalmic suspension, and moxifloxacin hydrochloride, 0.5% ophthalmic solution, 4 times daily for 7 days. Participants completed patient-reported outcomes with laser in situ keratomyolysis that is PROWL questionnaire, and reported which I had better subjective vision at preoperative and postoperative 1 month, 3 month, 6 month, and 12-month visits. The validated PROWL questionnaire included standardized photographs of visual symptoms like glare, halos, starburst, and double vision for participants to refer to. Significantly bothersome symptoms were defined as questionnaire responses of very or extremely bothersome symptoms, and visual symptoms significantly affecting activities were defined as a lot of difficulty doing usual activities or so much difficulty that I can no longer do some of my usual activities. A scale score for from 0 to 100, that is 0 being worst to 100 best, was calculated from the participants' responses for presence and severity of each of the visual symptoms. Statistical analysis of the scale visual symptom scores was performed using PRISM with mixed effect model. Correlation analysis of visual symptoms with residual refractive error and uncorrected distant visual acuity was performed. Results: study was conducted between March 2017 to March 2021. 88 eyes of 44 participants were enrolled. 80 eyes of 40 participants were treated with Wolfram-guided femtosecond LASIK in one eye and SMILE in the contralateral eye. 3 participants withdrew preoperatively, and 1 participant was excluded after SMILE was aborted because of difficulty in removing refractive lenticule. The mean age was 34 plus minus 8 years, and there were 22 men and 18 women. The mean preoperative sphere was 4 plus minus 1.82 diopters and 4 plus minus 1.78 diopter in LASIK and SMILE group respectively. The mean preoperative cylinder was 0.6 plus minus 0.36 diopter and 0.46 plus minus 0.38 diopters in LASIK and SMILE group respectively. This is the tabular representation of subjective quality of vision in preferred eye. At preoperative visit, 10, that is 26%, and 6, that is 15% of 39 participants preferred vision from the eye that was undergoing LASIK and SMILE group respectively, and 23 out of 39, that is 59% of patients reported no difference. At postoperative 1 month, 23, that is 62%, and 4, that is 11% of 37 participants preferred vision from the eye that was underwent LASIK and SMILE group respectively, and 10 out of 37, that is 27% of patients reported no difference. When it is compared at the postoperative month 12 visit, 17, that is 46%, and 7, that is 19% of 37 participants preferred vision from the eye that was underwent LASIK and SMILE group respectively, and 13 out of 37, that is 35% of patients reported no difference. And here is the graphical representation of the subjective quality of vision in the preferred eye. On x-axis is the preoperative and postoperative subsequent month follow-up. On y-axis is the percentage of participants. Solid blue color bar denotes for LASIK, and line blue color bar denotes for SMILE, and gray color bar denotes for no difference. Here we can see at from preoperative to postoperative month 12 visits, more number of patients preferred vision from the eye that was underwent LASIK as compared with SMILE. This is the correlation between residual refractive error and uncorrected distant visual acuity with the presence of visual symptoms, severity of visual symptoms, and correlation at preferred eye at postoperative month 12 visit. For LASIK, SMILE, at the postoperative month 12 visit, the moderate correlation between the residual spherical equivalent refractive error and the severity of halos shows moderate correlation, that is p-value is less than 0.01, and at the similar correlation also shows there was also moderate correlation between uncorrected distant visual acuity and severity of halos, that is p-value is 0.1, and for starburst p-value is 0.4, and there was also a moderate correlation with uncorrected distant visual acuity, that is p-value is less than 0.01, and no correlation with residual spherical equivalent refractive error in LASIK group. Here is the tabular representation of scale score for the presence and severity of visual symptoms for double images, glare, halos, and starburst. The data shows there was no difference in the scale score for the presence and severity of visual symptoms for LASIK and SMILE group as compared from preoperative to postoperative 12 months. However, the incidence of visual symptoms, incidence of significantly bothersome visual symptoms, and incidence of visual symptoms significantly affecting activities for double images, glare, halos, and starburst show decreasing the incidence from preoperative to postoperative 12-month follow. Here is the graphical representation of the incidence of visual symptoms at each visit for double images, glare, starburst, and halos. Here we can see the incidence was decreasing from preoperative to postoperative month 12 follow. At the postoperative month 12 visit, 97% of participants reported they were overall happy and they underwent keratorefractive surgery in the study. Discussion. Damgard et al. And Angam et al. Studies have reported decreased patient-reported blurred vision in SMILE compared with LASIK eyes 1 month postoperatively, which was no longer observed at 3 months. Shishe et al. Reported higher rates of visual symptoms at postoperative day 1 and day 7 visits for SMILE compared with LASIK, but this difference was no longer present at 1 month. Schmelter et al. Study shows risk factors for experiencing adverse visual symptoms may include exceptional preoperative corrected distant visual acuity, a loss of uncorrected distant visual acuity compared with preoperative corrected distant visual acuity, older age, and postoperative anisometropia. In the current study, more participants preferred the vision from the eye that received LASIK. A difference was more pronounced at the postoperative month 1 and month 3 visits, but also persisted until the last available follow-up at 12 months. This prospective randomized contralateral eye study comparing patient-reported quality of vision and adverse visual symptoms in participants undergoing wavefront-guided 15-second LASIK and SMILE found excellent outcomes in each group. There was no difference in the presence or severity of adverse visual symptoms between two treatment groups, and there were fewer adverse visual symptoms at postoperative month 12 visit compared with preoperatively. What was known before this study, adverse visual symptoms can affect patient satisfaction after keratorefractive surgery. It is unclear whether SMILE may lead to fewer or less severe visual symptoms compared with LASIK. What this paper adds, there does not appear to be any difference in the presence in the patient-reported visual symptoms between LASIK and SMILE. Visual symptoms can improve after undergoing LASIK or SMILE compared with preoperatively. More patients may prefer vision from the LASIK in part because of uncorrected distant visual acuity. This study has numerous strengths. The contralateral eye design allows participants to directly compare the two treatment eyes for overall subjective quality of vision and visual symptoms. All procedures were performed by a single experienced surgeon, which is important given that steep learning curve for SMILE. The availability of both preoperative and postoperative data with high rates of completed visits over 12 months is essential to assess for the extent of changes postoperatively. Conclusion, the rate of visual symptoms were similar for LASIK and SMILE, and visual symptoms improved with time. More patients preferred vision from the eye that underwent LASIK compared with SMILE. Limitations, the main limitation of study is inability of a surgeon or participants to be masked to which eye received which treatment. Also, the study not objectively quantified, only subjective symptoms are considered. Now we move on to MARI score. First, we will see the methods. Study hypothesis is well defined. Study population, inclusion and exclusion criteria are well defined. Study period is well defined. Study design is prospective randomized contralateral eye study. Assignment, participants were randomized to receive LASIK or SMILE in their dominant eye and the other procedure in the contralateral eye. A single surgeon performed all surgeries. Assessment, patients were followed up for 12 months. Participants completed standardized questionnaire for each follow-up and scale score was calculated. Results, statistical tests were appropriate. Scale score for the presence of visual symptoms improved from the preoperative visit to postoperative month 12 visit. Interpretation, rates of visual symptoms were similar for LASIK and SMILE group, and visual symptoms improved with time. More patients preferred vision from the eye that underwent LASIK compared with SMILE. Extrapolation, LASIK has quick recovery, but it does not make statistically significant difference when compared with SMILE over the period of 12 months. Thank you.
Thank you, Dr. Mohan. I think I would like to congratulate you for such a concise presentation and putting down the entire paper in such a small time and very concise and brief. Before we move ahead to the statistical analysis by Dr. Sengupta sir, I would just like to have some comments from Dr. Praveen sir on the paper. Dr. Praveen, if you can just highlight your thoughts about this paper.
Thanks, Neeraj, and very nicely summarized by Dr. Mohan. And I think overall, the good thing about the paper is it says that refractive surgery is good for patients. Whatever kind of refractive surgery you do, there is improvement in their quality of life from the point of view of the scores. And I think 2 points that are important to sort of talk about here is the fact that unlike the traditional approach where you only report what is measured in the clinic from the point of view of visual functions, studies like this that actually look at quality of life scores actually tell us what the patient derives from the surgery. And in the future, these probably are going to become very common as well as more prevalent to report the outcomes of most surgeries. In fact, several insurance companies in the US now determine their insurance payouts by quality of life indices based on the surgical outcome for different surgeries, not just in ophthalmology, but several other surgeries as well. It is believed that in the future, this is going to be one of the metrics that will be used by insurance companies to decide on the amount that they will approve for different surgeons, for different patients, and for different healthcare systems as well. So this is becoming important. And I think right at the end, it's funny that this article was selected because about 3 weeks ago, we just submitted a very similar study that we conducted at LVP comparing SMILE and LASIK. In fact, Contura, LASIK, and SMILE. And maybe at the end of the discussion, I'll probably share a few slides on the outcomes of that study as well. Very interesting and also very similar to what was found here.
Before we move ahead, I would request Dr. Gaurav Luthra sir to share about this study.
Thanks, Dr. Archana. Yeah, so very nicely presented, and it's very interesting as well because we are seeing that big push for lenticle extraction in the last couple of years with 4 new platforms becoming available, and everybody trying to see whether they want to move from flap-based procedures or surface procedures towards lenticule. And these studies actually bring about better perspective of how you can judge various procedures, especially from this study we could see. And as Praveen said, I'm happy that that study tried to highlight that both procedures are great as far as satisfaction rates are concerned. So patients don't need to kind of if somebody is interested in literature, they won't find that refractive surgery is being kind of trolled or something. It is a great procedure. And yet, it kind of, brings about certain thing. One aspect, especially what they would prefer as far as the vision. Of course, there are more aspects to the surgery than just the, visual quality. More goes to, the safety protocols and, patient outcomes, precautions, and long-term stability. And there are lots of other parameters that can be studied. This is just one parameter which has been compared. And yet, it is obviously quite interesting to note. The one thing which, maybe can be put up for discussion about this is we are trying to compare a wavefront customized treatment, with a SMILE, which has no option for customization yet. And I'm not sure whether the eye design has cyclotorsion control because the Visumax does not. And, we are trying to treat significant astigmatism where we know already that it's a weaker point. And as well that whether the surgeon was equally proficient in both procedures or he was still on the learning curve for SMILE. We don't know anything about all that. So, I mean, all these things can be discussed. So let's go on.
If we can have Dr. Sunny Sengupta's reviews and maybe opinion about the statistical analysis done in the paper. Sir, if you can just highlight some statistics and what could have been done better.
Yeah, thank you so much, Neeraj, and very good evening, everyone. I think Dr. Praveen brought up a very important point of, something called sort of the entire thing comes under the gamut of health economics, where people talk about QALY is quality adjusted life years. And, that actually goes on to something called ICER, ICER, that is, I think that's an incremental cost effectiveness ratio or something like that. That is, so a lot of, insurances, national insurances like the NHS, they actually do a calculation and they see, whether that is affordable enough for, to pay for. So say, for example, femtosecond cataract is not sponsored by the NHS. That's because the quality and the ICER are not favorable enough in terms of improving quality of life significantly over what FACO is doing today. So yeah, so like he's already said, a lot of these quality health outcomes which are patient centric are sort of taking center stage generally. So so I think that's a great point. I'll quickly share a couple of I think I'll share my slide. Yeah, I think you're able to see my slide. So there are some annotations which I have done. So overall, when you look at the method section, this is when you call it a randomized control trial. So that's like the a study which gives us the maximum amount of evidence, isn't it? So a randomized control trial needs to be sort of be done properly and also reported properly. And we use something called the consort statement to report randomized clinical trials. So if you look at the consort checklist, and there are 21 points under that, and if you actually try and map all of these into that, you will find that it falls short by at least 50%. So at least 10 out of the 21 sections which are part of the consort checklist are not at all mentioned in this study. So I'm not sure how it was done, but it's a very casual attempt at reporting a randomized trial. Say for example, how was this randomization done, and how was allocation done? So these are very important in terms of how they were done, and all of that has not been mentioned. I think key inclusion criteria are pretty all right, but overall, how sample size calculation was done, and so 80 eyes of 40 patients seems to be slightly small in terms of what most randomized trials do. So let's remember that this is a single practice with only 2 authors. So for a single practice, I think that's a relatively large number of cases, but for a randomized trial, you should at least report what is the sample size calculation that you used for. And sample size calculation depends upon what is the estimated difference that you will think about, or it's like a guesstimate. So how much difference will there be between 2 groups? If you just for the uninitiated, if you think that there will be a small difference in the end, then your sample size is large, because you're trying to find small differences. And if you guesstimate that the sample, that the differences will be large, the sample size will be relatively small. So here they don't give us that guesstimate. So what is the difference that they thought would and based on what have they calculated the sample size? Again, if you see here, this is number of patients who preferred the which eye at which time point. So if you see here, obviously at post of 1 month and month 3, majority patients preferred the LASIK eye, or at least 2/3 preferred the LASIK eye, but then that number goes down. However, is there a significant difference here, right? So if you see SMILE, that number is on the rise, right? 11%, then 12%, then it jumps to 22%, and then 19%. So, all of these should actually have a p-value. So they should actually report a p-value right here and say whether there is this significant trend or not. That they say that these trends persist till month 12. However, if you see at month 12, these numbers are again, so about 35% prefer either eye, and 19% prefer the SMILE eye, right? So if you add these, you will get 54%. So you could also argue that 54% don't prefer any eye, or they prefer the SMILE eye, right? So this seems to have sort of neutralized overall, but yet 46 and 19% is quite a large difference overall. So agreed that these numbers are much larger, and 59 and 62% are obviously, even if you eyeball, you will know that most patients preferred LASIK. But then after 12 months, these trends are neutralizing. Is there a significant change or not is something that they don't report. So we need a p-value here. Again, I thought I'll bring up this point of something called mixed effect models. These are used when data has repeated measures. Here repeated measures is measures from both eyes, and also it is repeating over time, right? So this is where we use something called mixed effects models to neutralize for that, that kind of influence. Again, correlation analysis is not the best way to do statistics. So as far as possible, avoid that, because that does not give us any concrete or quantitative way of looking at data. So best is to use something called regression analysis, and here best would have been to use linear regression analysis, and you can compare scaled scores between 2 groups and report what was the differences between the 2. It's alarming that they don't report the UDV at all, right? What was the uncorrected distance vision in one group versus the other at different time points? I mean, I'm not able to find it. And, though they say that all of these changes are attributed to differences in UDVA, but they don't at all report that UDVA, right? So, so is SMILE like, like 0.12 and, LASIK is like 0 or whatever, that is something that they don't report at all. Again, if you see here, this is table 2, these are all negative associations. So UDVA and, this is UDVA and correlation with presence of visual symptoms, correlation with visual others. So, the better the UDVA, the worse, the better the, the symptoms are. So, UDVA clearly has a more important, sort of influence. So, what I'm trying to say here is this UDVA seems to be a confounder. So if patients, what if all patients have the same UDVA? Does LASIK still do better than SMILE? That is something that I think is a very important core question which statistics could answer in this kind of paper, where if you say, that, overall the numbers are small, but what if all patients had the same UDVA? Now, still do patients prefer LASIK over SMILE? I think that is something which can be answered only with regression analysis and not correlation. So, so that is sort of a little statistics. And lastly, when you look at these scores, the higher the number, the better the value, right? So if you see here preoperatively 88 and 88 in this, this is looking at visual symptoms, and then it gets better and better. So I'm not sure whether patient have visual symptoms even before the surgery. I would have expected there would be no visual symptoms. So these scores would be much higher preoperatively. They would go slightly down. So generally these, procedures will induce some amount of these symptoms. So the score would fall and then again recover. But here these trends are only, so I'm not sure whether preoperatively all of these patients have visual symptoms and they have glares and halos and all of that. So, so I would have expected the score to be much higher preoperatively, then go down at 1 month, 3 months, and then recover to preoperative levels at month 12. So, again, so if these scores are like this, and I'm not really sure how they're reliable they are and, how they have been reported, then sort of cast a shadow on exactly how, these questionnaires were administered and, how these things were done. So there are a few tips that I thought I might share.
Thank you, Dr. Sengupta, for that wonderful statistical analysis. And you've touched upon so many important points, and it becomes so easy when you explain it in that particular way. So thank you so much for that analysis. Then moving ahead, I would like to ask Dr. Praveen sir. So what are the factors governing the faster visual recovery after SMILE, and the factors causing slow recovery post-SMILE as compared to the first day with LASIK?
I think a couple of factors Gaurav already mentioned. The fact that SMILE is a non-customized procedure from the perspective of not correcting any aberrations in the eye, and also the fact that it doesn't have any cyclotorsion compensation. So if you don't control for the amount of cylinder in the selected patient, then you might have a slightly inferior outcome. Now, having said that, I think the interesting difference between SMILE and LASIK is the fact that SMILE tends to have more variability from the perspective of the surgeon, because based on the amount of energy that you use, the dissection technique that is used in SMILE as well, there can be variable outcomes. Whereas in LASIK, it is almost surgeon agnostic, because making a flap is done by the femtosecond laser. The delivery of the laser on the cornea does not have much variability at all, unless the surgeon is spending too much time in the delivery or between the flap lift and the delivery. And most surgeons will probably have the same kind of outcome. This is not so with SMILE, because early on in the learning curve, the amount of dissection that is done and the way the dissection is done, like Gaurav said earlier, can have an impact on the kind of outcome that you'll have. But the other reason why SMILE tends to have a slower visual recovery, and this is true, it's not untrue that SMILE patients tend to recover slowly. And if they're told about it before surgery, they usually are quite all right with it. If they're told that, hey, look, you're going to be seeing all right on day 1, but the last 5% of your clarity is going to take, say, 2-3 weeks, then most of them tend to wait for it. The main reason for this seems to be the fact that in LASIK, you have one interface. That is, you make the femtoflap and then you ablate, whereas in SMILE, you tend to have 2 interfaces of the femtosecond laser that creates the flap, which probably is the reason why it takes longer for these interfaces to heal. And that's probably also the reason why visual symptoms are more in the early post-op period. But it seems as if from the point of view of quality of vision and the quality that is perceived by the patient, the way they have randomized this to contralateral eye study, that is one eye SMILE and one eye LASIK, is interesting because, like all of you know, all our patients do this all the time and eat our heads about saying right eye, left eye, right eye, left eye. They keep comparing. So if you have two different surgical procedures in both the eyes, then again, I think I'm not sure if that's it offers a lot of value from the point of view of having the same potential optical pathway and visual system to compare the outcome of the surgeries. But the patient is always going to be comparing because he's undergone two procedures. They probably are going to read about it. They know which eye has gotten what. And I think there's going to be some element of bias in that as well. The other method of doing this is to actually do SMILE in both eyes, LASIK in both eyes, and just compare subjective symptoms there again. And that probably has less bias from the point of view of what is reported by the patients and what visual functions they perform, because this is a very subjective kind of study. All the reports are based on what the patient perceives. So that also probably is going to have some element of bias. Sorry for the long answer to a short question.
I will just continue with the comments that you've passed, and I'll ask one question to Dr. Gaurav Luthra, sir, and in fact everybody over here. I want to know how much role does personality play, and does anybody over here do a personality study or a questionnaire before doing these refractive surgeries for a patient? Because, like you said, patients will always come up with some complaints, even if they are 6'6". And will it actually make a difference if we have a questionnaire beforehand and then try to understand? Because there's a lot of personality questionnaires available online. They actually tell you what kind of a personality that person is. So can that be done before any refractive procedure for that matter?
Yeah, so I think that's very interesting. And actually, while we all do that, I mean, I'm sure all refractive surgeons are wary of operating on a patient whom they've not kind of talk to and try to understand their personality type, their expectations, and why they're seeking a refractive surgery. At least I don't like to operate anybody unless I've had a good discussion and chair time for a few minutes, like 10-15 minutes with the patient of why they want a surgery, what do they expect from it. And there also nowadays it makes sense to even ask them that, have you read up about all the procedures available, and what is your personal preference and why? Because that helps you understand what they're expecting from it and what they have come seeking as well. Many times if you try to offer them a procedure and push a procedure which they didn't come asking for, they will always they may not be really satisfied later on unless they are convinced. But yes, we don't use any questionnaire, but we do incorporate in our decision making discussions from am I audible?
Yes,
I
sir.
think we lost it. I'm sorry.
You're
Hello?
audible.
Able to hear
Audible.
you.
Hello?
Yeah. You're audible, sir.
Hello?
Hello.
Hello? Hello? I think I got disconnected for a while. I'm sorry. Can you hear me now?
Yes.
Okay. I don't know. I think it says my internet connection is unstable, but anyway, let me carry on. So I think this personality questionnaire would be a good thought, and I'm sure it's a good suggestion. We don't do it right now, but maybe we could customize one for refractive surgery patients and do that. But yes, this definitely plays a big role in setting right expectations and understanding what the patient has come to kind of seeking, and then trying to match them, because that definitely plays a role in post-op satisfactions.
Sir, then how do you, decide whether, what are the indications for preferring LASIK over SMILE or vice versa, like SMILE versus LASIK?
Okay. So see, how in my practice it works out is that there are people who are coming seeking correction. You have to again look at the expectations. Some people are coming for medical exams and they're purely looking at the procedure from the point of view of going on to get through a particular medical exam. Others are probably looking at it from a lifestyle point of view. They're sports people, or they are, or many of them are like computer users and they are looking at good results for that. So you have to then tailor make the treatment, and then once you talk to patients, you understand whether they are looking for maybe, I feel more comfortable offering Smile to many patients because of the inherent advantages of, not being a flap-based procedure and, minimal precautions and long-term stability that's been shown in many studies. But if I realize that a patient is very, very fussy about, his quality of vision and, especially if he's showing significant astigmatism or corneal aberrations, I will try to take that patient towards a Contura kind of a treatment, because I know that they will do extremely well with that. Those satisfaction rates are much higher. And if I have a patient with, largely a spherical power, looking for higher safety, person maybe going for marriage and not very high visual expectations, I would mention that, are you looking for the highest safety, or are you looking for the highest, visual outcome that is achievable? And then I can kind of guide them into the kind of procedure that I'm doing. But that said, I would feel that today I don't enjoy making flaps. That definitely, and I think Praveen doesn't enjoy making flaps either. He goes the surface way, I go more the smile way. And flaps are now becoming more and more things that, are threshold for, refusing surgery or trying to, cut down on how much we can weaken the cornea with flaps. And ablation has, it's been a scene, there's a sea change in how we are kind of looking at that. So, switching to an ICL more easily now, and maybe, switching to Smile or surface ablation, our numbers for LASIK have gone down tremendously. I mean, I don't know. I mean, we can discuss this amongst others as well.
Dr. Praveen, your comments on this same question?
I think the one part that I will agree with Gaurav is the fact that if you have someone who is very finicky about their outcomes and also about their vision quality and recovery, I probably would advise them a laser procedure. Excimer laser procedure could be probably a PRK or a LASIK as compared to a Smile. Again, we offer both Smile as well as LASIK as well as surface ablation. So the line that divides LASIK and Smile is a very fine line. And at the end of the day, we let patients pick what they want after explaining to them, like, hey, this is what Smile is, this is what LASIK is, this is the advantage, this is the disadvantage. But if I sense, like you said, that there is a patient who might be very finicky, I will sort of guide them towards a laser procedure rather than towards a Smile.
We have one question in the chat box before we go ahead with other questions. Is dry eye problem after refractive surgery? So what Dr. Rahul Jain is trying to ask is that dry eye, is it more common in lenticule extraction, or has lenticule extraction solved the problem of dry eye? That's the question probably. Or is it? Any study done by LVPI which says that dry eyes is less post-refractive surgery, say post-Smile, as compared to LASIK?
Can I share my slides and show you what we found?
Yes.
Yeah, very quickly. This actually, this is something that we submitted, like I was saying, about 3 weeks ago. And it's funny that this came up at this time. And this is an interesting study because this was supported by both companies equally, both by Alcon as well as by Zeiss. And I won't go through the visual outcomes and all those things, accuracy. But since the question is more about dry eye, so this is the comparison between the dry eye parameters that we measured between femtosecond LASIK and Smile. Again, completely randomized patients, 40 patients, 80 patients total in each group. So we had almost no difference in the preoperative Schirmer's, the TMH, the tear meniscus height. The T-butt seemed to show some statistical difference where the T-butt actually was worse off in Smile as compared to LASIK in the early post-op period, but then it seemed to recover to be about the same. Again, we found that the FT-butt and the T-butt average between the two also was really no different. So to answer that question, we actually looked at this very carefully, and we found that from the point of view of the objective scoring of dry eye, from the point of view of what you can measure, there seems to be no difference in the first 3 months between LASIK and Smile.
Dr. Gaurav sir, I would also like to know from my point of view, because I've just started doing LASIK a year and a half ago in private cases. How much importance do you give for orthoptic exercises, orthoptic evaluation before probably carrying out a LASIK or a SMILE? Because you are a SMILE person, I know. So what role does it play in SMILE also, I would like to know.
I think it plays an equal role. I mean, for all refractive surgeries, we actually do an orthoptic checkup compulsorily for all patients, and that helps in picking up those patients who may or may not do well. And even post-operatively, I've seen that many patients, their symptoms with ability to fuse, and especially with SMILE, if patients are finding some difficulty initially reading convergence exercises and stuff, really helps them improve better much faster. But yes, an orthoptic checkup should be done for every patient for sure, all refractive surgery for that matter, not just LASIK or SMILE.
So I have a question for both the panelists. So we hear a lot about contrast sensitivity, and a lot of machines are giving us objective parameters like MTF and all. So do you all routinely for your patients post-op and pre-op measure contrast sensitivity? And if you do, then which particular machine do you do? What is the method of checking that? Gaurav sir, Praveen sir. Yeah.
I can answer that from the practical point of view. Contrast sensitivity, I think, is for research papers. In a practical scenario, in a busy refractive clinic, it is next to impossible to be able to check for low contrast visual acuity in either of these procedures. I think the amount of time that it takes and the value that you derive from the results of that test is probably not practical. Now, having said that, again, I'll probably share my screen again because you asked a specific question about contrast and about aberrations. Now, this is a previously done study that we published in Optometry and Vision Science about 3 years ago. 3 years ago, yeah. So this was a comparison between the image quality between PRK, LASIK, and SMILE. And I won't show you the detailed graphs, but this is all the methodology and very similar refractive errors of patients between LASIK, SMILE, and PRK. The interesting part here was in this previous study that we did, the aberrations that were present after LASIK and PRK were higher than the aberrations on an average, higher order aberrations that were present after SMILE. Though preoperatively, all three groups of patients had the same amount of aberrations. So interestingly, we looked at the high contrast visual acuity. There was no difference in the logMAR high contrast visual acuity between LASIK, PRK, and SMILE. But low contrast visual acuity, actually, it seemed as if SMILE did a little better than both LASIK and PRK. So again, like I said, this is more from the point of view of the study. But again, in a real life scenario in the clinic, it probably is very difficult to actually replicate. Now, this was in the previous iteration. I'll actually show you the outcomes of the very briefly about MTF and also the scatter index between these two procedures. And this was a much more detailed kind of study where we looked at the different kind of higher order aberrations between the two procedures. And we actually found that in this study, when we compared topo-guided versus SMILE, we found that very minimally the patients with SMILE had slightly higher overall corneal aberrations as compared to those with topo-guided LASIK. And the scatter index with patients with SMILE at 3 months and 1 month was slightly higher than those who had LASIK. Again, this is probably splitting hairs. In a real life scenario, you probably will not find much difference between somebody who has a scatter index of 0.5 and 0.7. It's just numbers. But if you want to really go to that level of granularity and assess what is the actual difference between the two, it is again variable. In the same study done in the same institute by the same people, the previous study seemed to show that visual function-wise, low contrast visual acuity SMILE performed better. But in the next study that we did, from the objective evaluation, we found that the objective test, LASIK performed better than SMILE. The difference was in the previous study, it was wavefront guided treatment using a different platform. On this study, it was the Contoura that we did.
Okay, so moving ahead, I would like to ask Dr. Gaurav sir. Sir, with high cylinders, I mean, for example, if the cylinder is more than 3, what is, I mean, according to you, which is the better modality to treat, like LASIK or SMILE for high cylinder?
No, luckily, because I do both topo guided as Praveen does Contoura and SMILE, and I've been doing them for about the same duration, about 7-8 years now. I find that definitely with significant astigmatism, I would be definitely veering towards a Contoura-based treatment, a topo guided treatment with cyclotorsion control. It definitely has its plus points, and there's no reason why we should not offer that to a patient. And I would only offer SMILE for patients. My cutoff for SMILE is say about 2.5 diopters. So that's about the highest that I treat for astigmatism. That too, if that is not the higher, this astigmatism is not the predominant, correction. If I'm doing let's say a 5 or 6 diopters of sphere and about 1.5 to 2 diopters of astigmatism, I will still usually get a great outcome. But if I'm looking at somebody with, say, just a 1 diopter of sphere and maybe 2.5 diopters of cylinder, I will start looking towards, because then his predominant correction is the astigmatism. I will move to a cyclotorsion controlled topo guided, Contoura kind of a treatment. So definitely.
Praveen, I want to ask one question. What is the tolerance of these procedures to decentration? So if you have to compare SMILE versus LASIK and decentration in either procedure, what do you think patient would tolerate better? Or it has less of decentration?
I think again, like Gaurav said earlier, probably not fair to compare the two platforms from the point of view of centration, because excimer laser, you have a mechanism to center the ablation on the pupil, or if you want on the apex of the cornea as well, by ensuring that you have infrared lasers, cameras that track the pupil and also ensure that decentration is minimized. With SMILE, this is going to be more subjective again, based on what the surgeon believes is the optical or the visual axis. And so the likelihood of decentration is probably a little bit more with SMILE as compared to LASIK. And several years ago, I think Jodhbir Mehta published a study about the decentration in the treatment for SMILE patients. And I don't remember the actual values, but he found that it was significantly more than what you get with LASIK. But then again, the counter there was the fact that you have a larger effective optic zone with SMILE as compared to LASIK. And so, and since we don't really take into account pupil size as a very objective measure, especially mesopaque, when evaluating the patients, I think I would probably be guessing when I say that it probably doesn't seem to be very different between the two. Asking for a very objective answer, I don't think I have an objective answer, but at least anecdotally, I would say that there doesn't seem to be much difference.
Another question is that how do you counsel your patient? Because if you see our population, most of the patients, you would not see them on follow-up, long follow-ups. And if we say that SMILE is not going to have a higher amount of patient dissatisfaction in the initial few months, how do we justify this procedure to the patient in our counseling?
I think patient satisfaction or dissatisfaction all depends on what you tell them preoperatively. If you promise them the moon and say that, hey, this is what you're going to get, and they don't get that immediately post-op, I think that is the biggest cause for disappointment. If you set expectations and tell them that, look, this is going to take a little while longer, this is the healing process, and it's going to take 3 weeks, very rarely do people actually complain about the fact that they have poor vision or their vision is taking longer. Because unlike the study, they don't have another eye to compare this with.
I absolutely agree, Praveen. In fact, because, in fact, the study itself showed, this particular study itself showed satisfaction rates were high. And I see good satisfaction rates with my PRK patients. I see good satisfaction with my LASIK patients and SMILE patients, as long as you've kept them informed about what to expect and they know it. Absolutely correct. And I think visual, Praveen, have you noticed that, I know that in my first 100 eyes on SMILE, we were seeing more of 612s and 618s day one post-op, and, maybe a week or two before they settle down, because your technique of, dissection and tissue handling and the time taken in the procedure and everything was longer. And we saw significant improvements. Now, most of my SMILE patients on day one post-op are 6'6", and or if not 6'6", maybe 6'9". And yes, I would still, if I compare them with my LASIK or Contura patients, I would notice a small difference in recovery of this thing, but it's not enough that I should be worrying about. And I don't give different expectations to patients when I'm offering them LASIK or SMILE, frankly.
Yeah, very true.
Is this going to change with the latest lenticule-based surgeries or platforms that have come into the market? 4 of them or 3 of them?
I don't have experience, and
Yes.
at least from what I read from individual surgeon experience, everybody is thrilled with the outcomes that they're having, which is typical for any new surgical procedure. So I don't know if I can comment on that. So.
And what about the hyperopic treatment for SMILE? Is it going to be more promising as compared to LASIK?
Can't say. I think, because the trials were over like several years back, they've still not been able to get approvals for that. So Zeiss has been promising it. When I bought my machine 7 years back, they were promising it within a year. It's been 7 years now. And then when they launched the VisuMax 800 about a year or two back, they said it'll come with that. They still don't have it. But Kishore Pradhan, who did many of these things in Kathmandu, says that he was quite impressed. But that's the problem. As Praveen said, everybody seems to be very happy with their own machines. And frankly, going by past experience with SMILE, it has a slower, your machines and your nomograms take much more time to kind of settle down. So I would be a bench sitter, like fence sitter on the machines, that few new platforms, until we have at least a year or two of, comparative outcomes from centers which do both, and you have honest opinions about how one machine compares to the other. And it is not a very easy thing to make nomograms work in the early days, especially that they've changed that to the biconvex lenticule, and there's some changes that are going on, but other things might be better. For example, the newer platforms, including the VisuMax, will have cyclotorsion control, and you will have better options to center the thing, and all these things might actually improve outcomes for all platforms, but remains to be seen. It'll take time. It's not going to happen very fast.
Yeah, I think we have any other more questions, Neeraj, because we are almost.
Just to sum up, I would just like to ask the panelists, what do you think are the moral to be taken from this paper? Do we consider it that more patients would be satisfied with the SMILE LASIK vision as compared to the SMILE vision, or we cannot take that on face value of what is given, even to Sengupta sir, based on the outcomes of this paper? Because that is what the paper is actually stating, right, in the model, that more patients would be satisfied with the vision from the LASIK eye as compared to the SMILE eye.
You want me to go first?
Yes, please.
Well, I'm a veterinary surgeon, so I'm far away from these things.
Yeah, so but based on this paper itself, like I don't have a SMILE machine, so I'll use this paper to show my patients that patients are preferring vision in the LASIK eye. So.
Right. So my background is that most patients are happy with 6x60, and they have no aberrations at all. Because it's not possible for them to have aberrations. However, looking at the study from a serious point of view, so there are problems in the way it's being. I think overall, even if so they have used a questionnaire which has actually been published in JAMA in 2016 and again 2018. And if you look at the questions that are being asked and the the kind of images which are being shown for them to score, there's a lot of subjectivity. Even if I try to do it, there's a lot of subjectivity there. So without objective background in terms of like the LV Prasad paper showed us a lot of objective values in terms of higher order aberrations as well. Without that background, at least set aside everything else, unless you have both subjective as well as objective, And there can be a lot of variability, like the LV Prasad paper before and after are relatively different, right? So simply because that they don't have a objective way of also comparing, I would not really given the other fallacies which I've already told before, but without a coexistent objective sort of way of looking at it, I would not give it much importance.
Praveen.
I agree. And maybe the only takeaway is don't do LASIK in one eye and smile in one eye. Do same procedure in both eyes.
Dr. Gaurav.
Yeah, I think all procedures are good. Wherever I speak and whatever I speak about, if you do them correctly, each procedure has its indications, and they are all good procedures. And refractive surgeons should probably be not trying to say that this is better than that or that is better than this, and because it's ultimately how your patient is going to be happy, and what you can do to make them satisfied is what you should be offering them. Rarely it so happens also that but you may not be offering a particular procedure which a patient would actually be best with. So one may not, it's very difficult to do that, but maybe a good idea to just refer him for that, rather than regret later. And yes, Praveen, there have been occasional instances where patients walked in, either insisting on Contura or insisting on, and you found that, they were more likely to do better with the other one. And they have actually gone on in my practice to choose one procedure in one eye and in the other. I try to resist that so often, but I have done it in a few patients where, we did smile for one eye because it had a much higher correction for sphere, and the other one had a smaller correction with more astigmatism, and we went ahead and did a Contura for them. And frankly, I have not seen them kind of, they do compare, but if you counsel them right, even with one eye what this and one eye that, if you tell them, please don't compare your two eyes, you kind of build the right expectations, even that does not trouble them so much. But yes, it should be just done only in those extreme cases where, there is a very clear indication to choose one over the other. But that said, other than that, I think choosing the right procedure, and all of them are good procedures. Everything works well. Even, kind of microkeratome LASIK used to give us great results, and I don't regret doing huge numbers of microkeratome LASIK. And
are there any other questions from the other panelists? So I think we can conclude. Dr. Vaishal?
Vaishal sir, you're on mute.
So it's been a great discussion today, and I thank Dr. Gaurav and Dr. Praveen for bringing out salient points, and it's been really insightful. And Dr. Sengupta, your statistical analysis was also really eye-opener. So I would ask Zen to give the Thanksgiving.
I think a wonderful moderation by Dr. Archana Vare and Neeraj, because they did a wonderful job today. Mohan also presented well.
Mohan, excellent presentation. You really, presented well, got out all the points of the paper well. So I thank you for presenting. Dr. Archana ma'am, thank you so much for moderating this session so well, and taking the time out and studying the paper and analyzing it. I would like to thank Dr. Praveen sir, Dr. Gaurav Luthra sir for their insightful comments into the article. And it was really a good discussion. It brought out brought a lot of practical points on what ultimately is the way forward. And definitely these lenticule-based procedures are here to stay. And thank you, Dr. Sengupta sir, for your valuable comments on the statistical part of the study. Dr. Vaishal sir, I think
we thank the NTOD. We thank NTOD for giving us this platform, a webinar platform, and we thank the MOS and the BOA executive members for joining here, and hope to join again. The coming Journal Club meeting is on 28th of February. It's a Wednesday, and the last Wednesday of the February month. So do join us, and it'll be another interesting topic to discuss on. Thank you again, everyone. Meet you soon again. Thank you. Adios.
BOA is doing a great job with this.
Yeah, Dr. Praveen.
Thank you so much.
Right.
Very unique, very unique. Thank you very much.
Good night.
Good night.